welcome to our show tonight. Our topic is the future of healthcare in the United States. I'm your host, Michael Uhila, and joining me tonight as the co-host is Amanda AKass, who's a journalist from England. Welcome to the show.
Thank you very much, Michael.
All right. We also have expert panelists to speak about healthcare. A lot of people know that Obamacare is going to be taking effect on October 1st, and so you also did some extensive research on this, right?
Yeah, well, looking at some of the background figures, the American healthcare system is absolutely huge. It's the biggest in the world and it's the most expensive. It takes up a fifth of the country's entire wealth every year. Last year, the bill was $2.7 trillion. That works out at around $8,200 a person. But it's not necessarily the best value system in the world when you compare it with other similar countries like the UK, for example, France, Sweden, Japan, countries like that. They have very similar healthcare outcomes, but they spend 2.5 times less per person. So it's quite an extreme difference.
So in theory, everyone's going to have to get health insurance, is that correct?
Absolutely. Well, as you mentioned before, October the 1st is the date that the health insurance exchanges are going to go live and people can start signing up for their insurance, and the date for that to start will be in January the 1st. So in theory, anyone whose employer doesn't cover them for health insurance does have to go online and choose a plan of the several different options that they will have there, which will offer a certain minimum level of coverage. There will be some tax rebates to help people do that, and there are changes to the way that the whole insurance system runs. So, for example, people with pre-existing conditions who couldn't get coverage before are now going to be able to get coverage. So the federal government estimates around 23 million of the 50 million people who don't currently have insurance will get coverage. The other element of the Affordable Care Act from the federal government point of view is wanting to expand Medicaid. So they want people who earn up to just over $15,000 a year, so that's 133% of the federal poverty level, to be able to have access to Medicaid. But the states actually have the choice as to whether they want to accept that federal funding and take that up and offer it to the people in their states. And actually, so far at this stage, only 20 of the states have signed up for that. So not everyone is going to have access to that either.
What about California?
Well, in California, there's 6.6 million people who don't have insurance at the moment. That's a fifth of the entire state. And in California, well, the state Senate, has voted to support expanding the Californian version of Medicaid. But Governor Brown has also indicated he's concerned about costs. They're not sure how long the federal government will perhaps continue funding this expanded Medicaid. So he's saying, well, actually, other benefits, certain elements might have to be cut back. So even here, there's still a great deal of uncertainty about what's going to happen.
And what if you get sick or you're uninsured and you go in to the hospital? What happens then?
Yeah, well, we know, a lot of people just hold on for as long as they can. They don't have any, there aren't very many options if you're not insured. So a lot of people end up going to, ER to have any kind of healthcare. And then by that point, their conditions are so severe that the bills are absolutely astronomical, and then premiums go up for everyone else. So there are a few free clinics that offer primary care. And for example, there's one in Menlo Park called the Arbor Free Clinic, which I actually went to visit a couple of weekends ago. And, that was set up by a group of Stanford students 20 years ago. It's run by volunteer doctors and students, one Sunday morning. And people there, it was interesting, they're all very positive about the health reforms, of course, but they don't think that, they're going to be going out of business anytime soon. So, yeah, we can probably have a watch of that now.
We have that roll-in ready?
Most of our patients don't have health insurance, or they're underinsured. They're not able to get the care they need on their current insurance program. Most of them would be considered low income. Many of them don't speak English as a first language. So for many reasons, they're not able to get care as part of the regular healthcare system. We do have to turn people away. I think we turn away patients every week. We can usually see about 15 patients every Sunday. For those patients who we aren't able to see that week, we would give them a referral to another location for medical care, another community health center. But it's tough because Arbor is a free clinic, and anywhere else that they would get care, it would cost something. So
The most common type of cases we see are probably chronic cases. I mean, patients that really need health care but haven't had the opportunity to get it, and maybe they've been putting it off for a while because it's difficult to access the health care. So by the time they come to us, these problems have developed for a long time, and we just do our best to try to plug them into the system.
My mother has multiple myeloma. We're actually looking for more information to improve her quality of life. She's in her 7th year. When it comes to people with sicknesses or diseases, they should be looked at or taken care of, even if they have insurance or not. Even I don't have insurance, so I have to look for places like this. The cost of insurance is very high. It gets scary, it gets scary. And then being all stressed out about that doesn't help. It'd be less stressful if there was more places like this to come to.
My dream would actually be our clinic would not be needed. It's ironic that to have a dream that your clinic is actually not necessary. As our previous dean in the Stanford Medical School said, Dean Pizzo, was that, by us not being needed, then that would mean that we would have a unique healthcare system where everyone was covered. But I don't think that's going to be the case. I mean, I clearly see that there are people that are not going to fit into this system with the new Affordable Care Act. Clearly it would help. I mean, there are a number of people that will get health insurance with the Affordable Care Act, but I can tell you today, some of the examples that we saw are not going to be covered, and so we're still going to be in existence, but hopefully not as busy. It's really a crime that we don't have everybody in this country covered for health care insurance, and I think it actually costs us in the long run. It's ironic. I mean, we think, oh, we're saving money, but these patients end up late on in their disease getting care, and we know that care is more expensive, getting care in the emergency room when there's an exacerbation of their chronic disease that has gone unchecked. If we do a better job at screening and we do a better job at providing comprehensive care, this wouldn't happen.
So now we've been joined by our panel of local experts. So thank you very much for being with us this evening. From the right, we have Dr. Gary Greenswag, who is the Chief Physician Executive at Dignity Health, which is the largest hospital system in California and the 5th biggest in the whole country. And next to him, we have Srija Srinivasan, if that's right, who is the Director of Strategic Operations at the San Mateo County Health System, which is a county health department known for carrying out a very forward-looking health agenda. Thank you. And here to my left we have Chini Krishnan, who is the CEO of GetInsured.com, which is a website which enables people to compare different health insurance policies. And the company has been involved with helping the state of California set up a health exchange. And lastly, we have Rhonda McClinton-Brown, who is Executive Director of the Stanford Office of Community Health at the Stanford University School of Medicine. So thank you very much indeed for being with us. So to start with, just off the back of that clip there, we'll start with Gary. I mean, there are a lot of issues in the background of the health industry, as we've been discussing, a lot of things that have perhaps need to change. In your view, why is health reform necessary, and why is it necessary now?
Amanda, I think you summarized it quite well. It's cost, value, quality, and the number of uninsured. If you look at our country over the last 7 years, the amount of money, last several years, the amount of money that we have spent on healthcare not only is greater than anywhere else in the world, but the rate of spending is rising dramatically. And I think if you look at the economic downturn of the last several years, there's a direct relationship between what we spend on healthcare versus what we receive and how that affects the economy as a whole. If you look at value, we spend more than anyone else in the world. We are 37th compared to many other developed and non-developed countries in terms of our quality outcomes, mortality, infant mortality, vaccination status, chronic disease management. And so we spend the most, but really our quality does not measure up. Two last things. One is there's really not a link between what we spend and the quality that we have. One of the CMS leaders several years ago said something to the effect of, it's unusual that we pay the same amount for every hip replacement in Boston, regardless of the outcomes or the quality. And last, and probably most importantly, I think it's an ethical and moral dilemma, the number of uninsured patients, people, families in this country that don't have access to health care on a daily basis.
Mm-hmm. And how well do you think, Srija, I mean, perhaps to go to you next, I mean, how well do you think the reforms are going to address those issues that Gary's just raised there?
Well, the reforms are historic, and it's a huge public policy milestone for our country and a long time coming. Advocacy for many decades. So they go a long way, and many millions stand to gain, many uninsured in the country and many uninsured in our neighborhoods. Not everyone will end up being insured. It's not completely universal. There will be people who are left out. There will be people who remain uninsured, and we'll still sadly have a need for a healthcare safety net for a number of reasons, so that access is actually related to coverage, that coverage alone doesn't get you access without a system of care and providers to provide that access. And we still have some challenges ahead in terms of bending the cost curve and having a more equitable and healthy nation.
Yes, and I mean, Rhonda, in terms of the clinics that provide free care at the moment, we heard Dr. Ostenberg during that clip talking about people, the fact that it's still going to stay open because not everyone is going to be covered, as Shreya mentioned, falling through the gap. I mean, what's your perspective on that?
I think there will always be people falling through the cracks. I think that the Affordable Care Act certainly intends to insure many, but there are some populations that will be left without and are not going to be covered through the Affordable Care Act. So those populations will continue to be uninsured. And then I think some of those who might be eligible still won't find their way to the enrollment process or find their way to purchase insurance for some reason, for somehow. And so we still will have people who need services such as Arbor Free Clinic or other safety net services like county-operated public health clinics or nonprofit community health centers. I think will still be in existence, unfortunately, because people will still need the services.
And as you mentioned there, it's a very complex issue. A lot of people perhaps don't know what they're going to be doing, particularly if they haven't had this integration with the health system before. Chini, can you perhaps give us a bit of an overview of how the insurance exchange is going to work, what people need to know, and how they're going to be able to access the system?
Of course. The first thing that most people need to know is that the new health insurance exchanges, they are online marketplaces that simply make it easy for people to, access the tax subsidies that most Americans are eligible for, compare health insurance plans, and buy a plan. So they are vehicles that help really all of us as Americans and as Californians get onboarded and obtain the health insurance plan, which is really a linchpin of healthcare reform. And California is unique in this regard, in that I think that it's really sort of set the pace for many other states to follow in terms of the scale and size of what we are doing here in the state, and in terms of all the efforts and community outreach that we're going to be undertaking here in the state to reach out to all of our population. It's historic in nature, and as Srija and others said, I think this is historic in scope. I think it'll have many chapters to the story, but what we are undertaking here as a first step is truly monumental in nature.
It's certainly it's good to hear that California is leading the way. And I mean, do you think how the actual health system itself is ready for this influx of people to come? I mean, do we have enough physicians? Are people ready for, people who are going to come into the system not having experienced it before, perhaps with different levels of kind of chronic conditions? Gary and Srija would be interested to hear.
I think I would make a series of comments. The first one is this will probably be messy. It won't be sort of totally without problems, but it is a huge step in the right direction. I think that there has been a strong move towards more providers, but we will continue to struggle with that, particularly in the area of primary care. And the last thing, which we don't talk very much about, but the exchanges and the entire premise of funding for national health care reform is really at levels much lower than all of us, and particularly on the hospital side, are used to. And so I think we will see the hospital-based providers and all providers struggle under the reimbursement issues that will arise. And it will stress the system a great deal. And I think that we will see some providers and some hospitals not make it through this. And so that's why I say messy is probably the best way to.
Yeah.
Doesn't mean we shouldn't do it, but
Yeah.
it would be messy.
Messy for a good end.
Yes, messy for good.
And I think to some extent we worry in the safety net about the strength of the safety net and the viability of the safety net to weather the challenges ahead. The recession has really put a toll not only on low-income Americans, but also on the healthcare providers that serve that population, and they're still going to be needed. They're still going to serve people on the Medicaid program and other programs who will rely on them for doctors and mental health professionals and other important services. And so as we balance the funding from different levels of government to support a viable safety net, we got to keep our eye on, do we have the providers in the places that people who are coming into coverage need them, and can treat them effectively in the right languages with cultural sensitivity and authenticity, and help actually translate insurance and coverage to health.
And how ready do you think we are at this stage with 5 months out before the exchanges go live?
I would just say this, that many patients are receiving care in the system today, but just in the wrong place. And so to the extent that we can unburden our emergency departments and put those people in outpatient clinics, in that regard, I think we have some readiness and we have some opportunity.
And in terms of the options of the kinds of insurance that people will be able to choose on the exchanges, can you tell us a bit more about that, Jimmy?
Sure, absolutely. You know, one of the things the Affordable Care Act has done is really made it simpler for people to compare health insurance plans. You know, it is very hard in our current market today for people to truly take plans, insurance plans, side by side and sort of know, you know, on an apples-to-apples basis, you know, which one is better. One of the great things that I think the Affordable Care Act does is it groups plans into 4 metallic categories called bronze, silver, gold, and platinum, where there's a great deal of harmonization on the kinds of benefits that a plan provides. And so, you know, what I think that does for the average consumer is that it allows sort of them to, you know, choose a particular layer, you know, level of plan, and then choose the plan that's most appropriate for their needs. And I would, you know, certainly in California commend the work that's being sort of done by the exchange to make sure that, you know, true principles of consumer advocacy are being taken into account here, and people, you know, are able to go ahead and, you know, compare and purchase these plans, you know, and ultimately, you know, have a plan that's going to be right for them.
So people will still feel that it's a product that is being purchased rather than some form of tax being enforced, would you say? Do you think that makes a difference?
I think one of the things that a lot of people don't realize is that the tax subsidies are very generous. You know, 2 out of 3 Americans under the age of 64 will be eligible for some form of a tax subsidy. And if you look at some of the data out there and look at, for example, you know, a family of 4 that makes $40,000 or $50,000, the kinds of subsidies that they get paid for are extremely generous and pay for an overwhelming majority of their care. And so, you know, and I think that has been a principal precept of the Affordable Care Act, where, you know, I think the way it's structured is to say that we all are required to participate, but that, you know, there is a true helping hand. And I think, you know, most Californians and most Americans, you know, are going to look at this and see that the elimination of pre-existing conditions, is going to make the market more fairer, and these tax subsidies are going to make it easier for the average consumer to buy these plans.
And can you give us an idea, obviously it's a broad spectrum, but in terms of the numbers we are talking about, I mean, a lot of people, if you have health coverage through your employer, it's something you're kind of a step away from in terms of the actual costs involved.
So there's two ways to sort of look at it. One is sort of broad demographics, and the numbers that we're talking about here are historic in nature. Over 35 million new people are expected to take advantage of the tax subsidies and enter and purchase health insurance plan through the exchanges in one form or another, and that includes the expansion of Medicaid, new children that will enter the chip, as well as the purchase of what are called qualified health plans, plans that are tax subsidized health plans that many of us will purchase. And we really haven't seen anything like this since Medicare and Medicaid, since the Johnson administration. So these are large numbers, and I think as Gary and Srija and others have said, I think the enrollment process that we're talking about here is historic and changing of society in many fundamental ways, and will likely be messy in ways that we can't predict.
Yeah.
But it's for a great cause. It's to expand coverage and to enable access to care for more of us here, in the United States.
And in terms of, we've been talking a lot about hospital kind of approaches to healthcare, very much at a point of need. I mean, what about in terms of community care, and perhaps Rhonda, I mean, from the broader, more holistic perspective of how people engage with the healthcare system, what can be done to stop them needing such care, so much expensive long-term care further down the line?
Well, I think once people have access to a medical home and have the ability to participate in the healthcare system, then I think it provides them more opportunity to be engaged in their own health for the long term. We don't necessarily have that system now where people have that long-term engagement with the healthcare system. And so I think as we're changing it, and as we're thinking more about prevention and management of conditions and all of the different components that are embedded with the system redesign portion of the Affordable Care Act, I think people will be able to have more ability to actively participate in their own health status.
And I would say yes, and in addition to anything we can do within the healthcare system, there are underlying changes in communities that are really propelling the rise in chronic disease and an unsustainable rise in healthcare costs. And unless we address those root community issues, how do people have incentives to to walk or ride their bike, or actively be active in their community? How do we make unhealthy food less attractive, more expensive, less available? How do we talk about wages and economic security and housing security so that there's not chronic stress on those at the lowest end of the economic spectrum? Those underlying healthcare health trends.
We all know that there's determinants of health that are beyond having access to care. I think access to care contributes 10 to 20% of our healthcare outcomes, but it's other things outside of the healthcare system that really impact people's health. And I think the system is beginning to look at that. If you look at Kaiser Permanente and some of their Thrive campaign kind of things, if you look at what public health departments and many community agencies are doing now, where they're looking at the environment in which people live and how to make the environment a more healthy environment so that people have choices to lead a healthier life, because we choose what we have available to choose. And so if we don't have options that provide us with the same equities that lead to healthy lives, then we have disparities.
The entire mechanism of payment will also change. That will help people focus on medical homes, chronic disease management, population health, and it will move the entire provider community to look at healthcare differently, I think, just as you've said. And so it's not business as usual, and that change in the way that payment will be made to providers and healthcare institutions and healthcare organizations, I think, will drive a lot of that.
So that's something further, perhaps, that's the next stage after this is, you know, all coming together in October and in January. What about even further down the line? I mean, this is very speculative, but how would you see it playing out in 5 years, 10 years, you know, what we think about what we mean by healthcare, really? Is that going to change?
Well, as Sir Isaac Newton said, for every action there's an equal and opposite reaction. So there has to be a pro and a con. So what are the cons of this healthcare system? What's bad, what's ugly, what doesn't work? We got a little bit of time left, but each one of you, starting with you, Doctor.
I would say that one thing that we will see is that part of the Healthcare Reform Act allows employers to bail out, if I may say, on coverage for their employees, pay a relatively small fine, and move their employees into the exchange model. So we will see a migration of people who today have private insurance into the exchanges. That will further stress the entire funding mechanism. So I think that's one of those hidden consequences, reaction, action, reaction, that we still have to deal with.
So we're going to have to spend more money or get more money, or
I think
taxpayers are going to have to they're going to get taxed more? Or?
We need to spend it more wisely. I think that's the key.
All right. And you?
I think there will still be people left out, and the people who are left out could be even more marginalized than they are now.
And that might be a big crack, right?
Well, we have to keep working on having an equitable system, not just a, you know, insurance system.
Okay.
I think the scale of what it is we're looking to do is enormous. So there'll be many things we will all discover along the way that, you know, will require fortitude and perseverance to address. So I think it's important to realize that this is really a step in a long journey.
I think we incrementalist. So I think we live in a market-driven society where we are making incremental changes towards insuring more people. We don't have a value in the United States around healthcare as a right and that everybody should be covered. So I think we will still have people that are left without, but many will have insurance, which is also a good thing.
All right. Well, thank you for watching, and tune in next time. Have a good night.
Thank you for joining us.
Thank you.
Thank you.
Thank you.
Thank you very
Thank you.
much.